Good afternoon, everyone. I wonder if we shouldn't just wait a minute or two more, just for a few more people to join. I can see there's still quite a few people joining.
Okay, I can run the presentation again.
Yeah, I think let's just wait till we get to over 20 or so.
Okay.
Good afternoon, everyone. Welcome to this ECHO session that's hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. These sessions are held every week on a Wednesday. Today we had 60 registrations from 13 different countries in Africa. We will open the chat for questions in between the talks, and at the end, if you have any questions, either just raise your hand or just put it in the chat, and we'll try and answer the questions. So this week the topic is management of hepatocellular carcinoma in the Free State province of South Africa. So we really are keen to show how different units in different parts of the continent are managing hepatocellular carcinoma, and we haven't until now had the team from the Free State present anything. So the presenters are going to be Dr. Colin Noel, Dr. Mazwi Punguchi, and Dr. Andrei Kopechnikov, and Colin's going to start.
All right, thanks very much, Mark, and thank you to the Gastro Foundation and to Project ECHO for this opportunity to speak. So let's go through. I just want to quickly get the slides. All right.
Oh, thanks. We can see that, Colin.
Oh, fantastic. Okay, so thanks. Yeah, thank you very much for the introduction, Mark, and for the opportunity to speak. So I've been asked to talk about hepatocellular carcinoma in the Free State, and I'm sure there are quite a lot of you that are wondering where the Free State is. So I'm just going to quickly get my laser pointer going. So we're going to start there. The Free State province is in the southernmost aspect of South Africa. So yes, we are from South Africa. We basically are classified as Central South Africa. So we really are in the center of South Africa, bordered by some of the larger provinces, but our drainage area is is quite large. So we do not only drain from the Free State, but also our sort of neighboring Northern Cape, as well as the northern parts of the Eastern Cape and Northwest. The Free State really has quite a unique topography and geology to it. We're very fortunate in the sense that we've got two of the largest rivers running through the Free State, being the Vaal River and the very gorgeous Orange River, which is on the left-hand side of the screen there. We also have two of South Africa's largest dams, being the Griep Dam, which is South Africa's largest dam, as well as the Sterkfontein Dam. The Free State province is known by the sort of locals as the Orange Free State, and that really comes down to the unique sunsets in the Free State, as well as the maize farming, which predominates the sort of the Free State province, giving the name Orange to it. But from a medical perspective, I'm based at Universitas Academic Hospital, which is the academic hospital that drains, or the tertiary level hospital that drains the Free State province, and we associated with the academic institution, the University of the Free State, which was established in 1904. So in order to give you a bit of insight into HCC in the Free State, I really need to go back into the history of our department and our unit, and we're very fortunate in that some of the pioneers of HPB surgery in South Africa come from the University of the Free State and Universitas. And in the picture there, you can see Professor or Dr. John Barry Fichard, who really pioneered endoscopy and introduced it into the government sector, or the state sector here in South Africa in the 1960s. And then Professor Bornman, which I'm sure a lot of you are familiar with, and Professor Barry, who sort of were pioneers in establishing the gastrointestinal unit here at Universitas. But looking at liver surgery specifically, it was really in 1986, under the guidance of Professor Reynold Barry, that the first liver resection, or minor liver resection, took place at our institution. 8 years later, again under Professor Reynold Barry, in 1994, saw the first major hepatectomy being performed here at our institution. And the indication back then was for colorectal liver mets. HCC at that time in our institution wasn't really considered a surgical pathology because of the underlying liver disease. And so they didn't embark on liver surgery for HCC till much later. HPB surgery as such really fell under the discipline of general surgery. And it was only in 1996 from Dr. John Barry Fichard that HPB surgery, together with breast and endocrine, split from general surgery and developed its own unit. But it was really in 2005, again by Professor Reynold Barry, that HPB developed its own separate unit from general surgery. And that really saw the growth of HPB surgery, and especially ERCPs in our institution. The modern HPB surgical unit really took effect in 2019, and that was when we introduced or did our first minimally invasive hepatectomy, as well as introduced local regional therapy to our unit here in the Free State. So relatively new, and as mentioned, it was really the birth of the modern HPB unit. So this is currently our team that we have here at the University of the Free State. Professor Barry has subsequently retired, but I've got some fantastic fellows and surgeons that hopefully are going to continue to see the growth that's happening here at the university. So one of the first things we had to do once the unit was established was really to provide frameworks for different pathologies, and HCC was amongst them. And so the framework that we essentially thought would be important was, with regards to HCC, was as follows. The first was to really target public healthcare. And really, with a complex disease like HCC, it's imperative that public healthcare, with regards to vaccinations, education around risk factors, are made aware not only to the patients, but also to the primary healthcare practitioners at those facilities. very important aspect is regarding public healthcare systems. And here really I'm talking and referring to the referral pathway. So once the patient's been identified, being able to expedite that patient to being seen at an area where he can receive appropriate medical care. And I think in rural areas or such as the Free State and a large proportion of Southern Africa, this is really the sort of the crux of a functioning program is expediting those patients that need to be seen at a specific facility. But at the same time, we recognize the importance of trying to develop standard operating procedures for medical practitioners at these primary healthcare facilities so that they can identify which patients need to be referred for more specialized care. The next was developing hepatology clinics, and this is around the Free State, run predominantly by our medical colleagues, but with the aim here of really managing the underlying liver disease as well as risk factors. But one of the most important aspects here is to try harness the ability to identify those patients who are at high risk for HCC so that they can benefit from surveillance programs and more specialized clinics. And that really is the sort of where the first centralized combined hepatology clinics comes into play here in the Free State. So this is an idea where hepatologists around the Free State identify those patients who are at high risk and then refer them through to a combined clinic run by both the surgical discipline as well as the medical discipline. And really here is to optimize the surveillance program so that we can start recognizing those patients with early HCC lesions and hopefully offer them some type of treatment. The next important factor really is once you've identified the underlying malignancy is to have a centralized, specialized MDT where one can come up with treatment plans appropriate to that specific stage. And I think HCC is one of those conditions that really lends itself to this notion. And included in the MDTs, is all the specialists from oncologists right through to clinical researchers who are hopefully collecting data. From here, there are really three aspects that we identified, and the first two are first and foremost a national HCC tumor registry, and this is something that we haven't got right yet here in South Africa, but something that I strongly believe in. It's only through knowing your local epidemiology and your local risk factors that one can actually target a specific pathology effectively. And then the second is that these MDTs give feedback to our hepatology clinics so that during the interim or interval periods between treatment that they can carry on with their ongoing management. And then the last arm from the centralized MDT is really those teams that are involved with the treatment. And that ranges from transplant right through to palliative care. Now, unfortunately, in the Free State, there are a number of these areas that we still haven't got right. And the ones that I've highlighted here in orange are those areas that we still are working on. For example, our interventional radiology, we do have the service, but with regards to liver interventional radiology, we really don't have much experience or sort of many treatment options in that degree. Lastly, the take-home message from this slide is that one needs to, with a disease as complicated and as complex as HCC, have an MDT approach. And that's not only because there's a prognostic benefit to this, but also that it improves the adjuncts around it, like palliative care. One can identify them earlier on in the disease course. So it really is important that an MDT approach takes place. So looking at the therapeutic options for HCC, I think most of the audience here will be familiar with them. Obviously, there's surgery, then there's the local regional therapies that range from microwave ablation right through to radiofrequency ablation and the local regional therapies like TACE. There's also the systemic treatment, and there's been a lot of advances recently in this, from chemotherapy to molecular targeted therapy and immunotherapy. And then obviously external beam radiation and liver transplant. So looking at these therapeutic options, really in the Free State, we come down to only three options: liver resection, or four options: liver resection, microwave ablation, We do have external beam radiation, although we very rarely use it, and then percutaneous ethanol injection. Chemotherapy or systemic treatments such as atezolizumab, bevacizumab, that combination, sorafenib, the cost of these treatments really preclude them from being implemented in a system such as ours. So we just don't have access to that. Another way of looking at this from a schematic perspective, and hopefully this gets the point across, I think everyone's familiar with the Barcelona staging and algorithm. If one looks at this, really in the free state, we're only able to offer treatment to those in the very early stage, as well as those requiring best supportive care. So the vast majority of people who present to our institution, we don't actually have treatment options for them. And that's something that really is alarming and something that I'm trying to address. So just a brief introduction to HCC. I think everyone's again going to be familiar with this before we look at the free state data. We know that it's the 6th commonest cause of cancer worldwide, the 4th leading cause of cancer-related mortality. HCC is the commonest primary malignancy of the liver. Alarmingly, still has the highest mortality rates in Africa and East Asia. Again, the incidence is increasing, so this is something that we do need to address. And internationally, there's reported a surgical resection as an option in up to 20 to 30% of patients, which is something that we definitely don't see. Looking at the incidence worldwide, in South Africa, it's between 3 to 5 per 100,000. So keep that in mind when I show you the data that we currently have and the history that I've put into perspective, hopefully put it into a bit of perspective. So this is just looking at the number of admissions to the different units, the blue being to our oncology unit and the orange being to the HPB unit since 2012, so over the last 10 years. And really you can see that there's a paucity of patients presenting to the tertiary academic hospital. Only an average of around 6 patients per year is what we are seeing being referred. And again, one can obviously appreciate and hopefully take into account the history of the HPB unit, that very few patients were referred to the surgical discipline. And only really after establishing the unit properly in 2019 have we seen the increase in referrals through to the surgical HPB unit. That's more or less in keeping with what's seen at our oncology units. I want to try to put this into perspective, largely, and this is going to hopefully speak to disease burden, which offers a couple of difficulties when it comes to trying to request funding and definitely resource implications. This is the same graph. I've just changed the vertical axis. So this is the HCC admissions over the last 10 years to the oncology and surgical unit. And in comparison, this is our potentially treatable pancreatic ductal adenocarcinoma load that is referred through to our institution. So you can see it's almost sort of 400-fold more than what we see in the HCC group. And again, you can just see the implications of establishing a unit in that as soon as a unit or formalized programs being established, the number of admissions increases. This graph, again, the blue and the orange is what you've seen previously, so that hasn't changed. What I've added here really is looking over the last 7 years, all those HCC confirmed histological cases submitted to the NHLS that come from the Free State province. And what you can see again is that, first of all, there's a paucity of numbers of HCCs being confirmed annually. But what is quite encouraging is that establishing and hopefully in the future will start tracking each other, which really represents that a program is starting to work and the patients are being seen by the relevant personnel. Our gender distribution is not much different to that seen or reported internationally. So looking over the last 10 years, our 74 admissions, we have males accounting for the vast majority, almost 80% of cases. Again, our mean age is not different to that reported. Might be slightly younger. Our mean age was 51 years old, but what is apparent is the discrepancy between male and females, and there is a significant difference between presentations or the mean age of those presenting with HCC to the Free State or our service. This for me is the most alarming slide. So this looks at treatment options available at time of presentation, and looking at the last 78 patients, unfortunately, we've only been able to provide some type of treatment to 5% of those patients. So again, really alarming statistics and something that needs to be addressed. This is the reason, though, currently for why we unable to provide treatment to a lot of our patients, is that more than 90% of our cases are really very advanced cases with high tumor burden. And as I mentioned previously, we don't have currently systemic treatment options available to us here in the Free State, which really limits our ability to make a difference. So I'm just going to run through one or two positive cases that have come out, and the case presentations will address a couple of other patients. So this was the 37-year-old male that presented to us, a Child-Pugh score of 7, had a MELD score of 8. The underlying etiology was chronic hepatitis B, or risk factor was chronic hepatitis B, and had a significantly raised alpha-fetoprotein. Unfortunately, don't have the right phases yet for you to look at, but what I want you to really show is the left lateral lobe, specifically 3 that was affected with a fairly well-defined hepatocellular carcinoma. So this patient underwent laparoscopic resection. The tumor size was 7 by 7. But what I wanted to mention here was really that on preoperative imaging, despite the MRI, we didn't appreciate the satellite nodules. They were very small and microscopic, and we only ended up getting 3 millimeter border or clear margins because of this. And this is one of the new indications, or one of the proposed indications for possible benefit of transplant upfront as opposed to resection. Patients now 3 years down the line, and on subsequent imaging, we don't have any evidence of recurrence, and the alpha-fetoprotein is well within normal, so it's very encouraging. The second case was a 24-year-old female that presented with right upper quadrant pain, had fairly well preserved completely well preserved liver. Alpha-fetoprotein was negative, and this is just a CT scan taking you through the different phases. And one can see in the arterial phase a fairly well-defined heterogeneous hyperdense lesion that it enhances on the arterial phase with early washout. You can also appreciate this hypodense central area that we initially had a differential of a fibrolamellar variant, with the differential being that of HCC with tumor necrosis or an atypical focal nodular hyperplasia. This patient underwent a right hepatectomy and confirmed the fibrolamellar variant. She's now 3 years down the line and no evidence of recurrence, which, as mentioned, although they're small victories in the bigger pool, are cases that we have been able to offer some type of treatment. So really in the Free State, we're sitting with this conundrum at the moment. We have this incongruency in treatment options and what our patients are presenting, so the disease presentation at the time. As I've sort of shown you before, 85% of our patients fall into a category that we can't offer any treatment for. 10% we're offering best supportive care, and only 5% of these patients are currently amenable to some type of treatment option that we have here in the Free State. We really do need for our provincial health department to start investing in HCC and in the program. But the conundrum here really is the cost implications, taking into account the disease burden and the prevalence of the disease. And the only way that one can advocate for this is really by having well-established, robust registries. And so I really am an advocate for a national hepatocellular or tumor registries where there's collaboration amongst us, and really in a platform like this to start promoting these registries amongst sub-Saharan Africa. So in summary, with regards to HCC in the Free State, it's imperative to establish a formal program. We currently have discrepancy between our disease and treatment options. We here in the Free State need to focus or tailor our approach and really focus on the
Thanks very much, Colin. That was very interesting, and I think having done these talks for some time, it becomes apparent that most people who are working in sub-Saharan Africa dealing with HCC have the same problems and the same issues. We've discussed trying. If you look at the disease presentation that you have in the Free State, you don't have transplantation readily available, but that's probably quite a small number of patients that are going to benefit. But TACE would potentially benefit, although it's not a curative treatment option, would potentially benefit quite a few patients. We've thought about whether it's practical to train maybe cardiologists or vascular surgeons or non-interventional radiologists if they're not available, but people who are already doing angiography to do TACE, and if that would not be a way of making TACE more readily available. Do you think that would be practical where you are?
Yeah, Mark, it's a very interesting question. I actually addressed it at the end of this. Again, I'm a big advocate for HPB surgeons expanding their skills. And I think modern HPB surgery, local regional therapy, and local ablative techniques becomes part of our armory that we need to be able to treat diseases. So I would be a big advocate for actually HPB surgeons themselves taking on this role. I think it is something that's feasible and something that not only that our college should hopefully look into the future. We have a paucity of interventional radiologists around the whole of South Africa, and it's not a technique that can't be learned. I think it's something that definitely is feasible for HPB surgeons to take on. So I would advocate that it actually falls under our discipline. I'm not sure if you have any.
No, so I mean, let's say we wanted to extend it to the Free State, because we're thinking of setting up a workshop here. The problem would be, let's say one of you guys came down, you still needing to learn how to do angiography. And I'm not saying you shouldn't do it in the long term, but if you wanted to train someone quickly who takes the skill back, a vascular surgeon comes, you probably be able to teach them how to do it in 1 or 2 days. They could then teach you guys how to do it. I'm just thinking of how you get it started, the simplest way of getting it started.
Yeah, I think angiography is definitely, the vascular surgeons are more familiar with it. Fortunately, having come from the general surgery background, I think a lot of the general surgeons who have moved on to HPB are familiar with at least the basics around angiography. Again, the question then becomes other areas like sort of tips and those areas. Again, the technology is improving. It's not going to be long before we start doing endoscopic tips, I don't think. And who's going to carry on with that? And I think a multidisciplinary approach is very attractive, but it's in resource liberal areas. I think in resource constrained areas, I would think I'd advocate for HPB surgeons taking on those and setting up a workshop and trying to, if you look at the number just for TACE, the learning curve for TACE isn't actually that steep comparative to something like EUS. I think TACE is around 20, whereby EUS is close on 300. And yet we're taking on those new areas. Okay. Yeah, I'm not sure.
And then just one other comment I have. I mean, I think one of the problems here is that, as HPB surgeons, we're seeing these patients with very advanced disease, and that's really a failure of primary healthcare and of medicine in general. Just picking up patients with hepatitis B and treating it, and that's a major problem. Trying to just get the message through who needs to be screened. But I was just thinking about, let's say you had a patient in like Bethlehem in the Free State who had hepatitis B or had cirrhosis. How easy would it be for them to be screened now? Who would do the ultrasound and that sort of thing? And, because it's a real problem. How do you get that patient screened? Do they have to go all the way to Bloemfontein to be screened? How would you do that?
Yeah. So Mark, going back to our proposed program. So what we've tried to do is identify those that are at high risk. So at relevant sort of medical clinics around the Free State province, those that are at high risk for HCC, those patients be centralized to a specific area or combined clinic. If you look at the screening, sort of at the moment, it's every 6 months. We have very minimal numbers of HCC patients. We only have 50 in our chronic hepatitis patients in our current sort of medical institution at the moment. So what we're proposing is that the high-risk patients be seen at a combined clinic where hepatologists and HPB surgeons are there. Here in the Free State, we do most of our own ultrasonography. So especially the more difficult ones, we do ourselves. We do have radiology available that can help. So if there is an area that we sort of concerned of, we'd ask them to sort of ramify what we're seeing. But I think historically, if you look at it, the peripheral hospitals are not set up to pick up these diseases. And that's why we're failing, in my opinion, is that we're seeing them so late. The program's been in place far before I arrived at here in the Free State. So something needs to change. And I think one way of doing this is by centralizing that service before HCC occurs. I think the other way to look at it is that HPB surgeons, because it's our pathology, are far more interested and far more keen to identify these small lesions. So where sort of an indeterminate lesion might be said, okay, let's follow that up in 6 months' time in a peripheral place because of zonal guidance. In our clinic, we will more than likely say, oh, let's follow it up with the MRI while the patient's here and see. So hopefully it's going to change. Okay.
All right. I don't see any other questions. I don't know who the next speaker, who you want to go next, Colin.
Mark, so I'm going to speak quickly about local ablation, the options and evidence, and then we've got 2 case reports from Dr. Guideline and.
Okay.
All right. Okay. So the second half of this talk is local ablation, options and evidence. So just to outline what I'm going to touch on, first of all, just the different options that are available. I think important, especially in resource-constrained environments, is to really keep in the back of the mind the natural history of this disease if untreated. Because if you know that, then you'll be able to say whether or not the latest data from international studies show benefit or increased benefit, there's still benefit to the traditional treatment options. And then I'm going to look at or just discuss the 3 commonly used techniques: radiofrequency ablation versus microwave, radiofrequency versus percutaneous ethanol injection, and then obviously radiofrequency versus the standard, which is, or the gold standard, which is resection. So these are the options that we have for local ablation. Like I said, I'm only going to touch on the first 3. There are other indications, but for me, really, there are 3 that one need to keep in mind. And the first is that group where you can treat, this is going to be the primary modality, and you're going for a potential curative intent. The second is a bridge to liver transplant. And then the third is in a combined modality, so RFA with TACE, to try and improve overall survival or improve recurrence-free survival. So I'm going to start at the natural history. So this was a retrospective study published in 2012. There were 320 patients, and what they really looked at was trying to look at the median survival stratified according to the Barcelona clinic liver cancer stage system. So I'm not sure this projects very well, but if one can see, what I just want to take home here is the overall survival, if left untreated in months, the median is very poor, so around 7 months. Okay, but when it comes to local ablative techniques, it's really the stage A and possibly the stage B that we need to compare to. And these are the numbers that I'd like you to keep in mind when we talk about the local ablative techniques. So the median survival for stage A is around 33 months. It's about half for the percent, and that falls off dramatically in a stage B if left untreated. So those are the numbers that I'd like you to keep in mind when we go through and look at the evidence. So obviously liver resection is the gold standard apart from transplant. So liver resection versus radiofrequency ablation. So this was addressed in this multi-center randomized controlled trial from the Japanese group. It was presented at the 2019 ASCO meeting. So we're still awaiting the overall survival results. But what they looked at was basically the efficacy of surgery versus radiofrequency ablation for small lesions, so lesions up to 3 centimeters. There were 145 odd patients in each arm, and really radiofrequency ablation fared quite well. So the 3-year recurrence-free survival of patients were essentially normal between the two groups. Okay. As I mentioned, the overall survival rate we're waiting for, and that should be published fairly soon. But with regards to recurrence-free survival, essentially normal with lesions up to 3 centimeters. The next paper that I'd like us to sort of touch on is this meta-analysis that was published in 2021 in the Annals of Surgery. And basically, they looked at local ablation versus versus liver resection in those who fall within the Milan criteria. So uniquely, there's a subgroup in this paper of patients that fall outside the Barcelona recommendations that they included. It involved just under 3,000 patients. In total, it was 7 randomized controlled trials and 18 matched non-randomized controlled trials. And again, radiofrequency ablation fared very well. So although local recurrence was better at 5 years in the resection group, and radiofrequency ablation had a slightly or significantly higher local recurrence rate, if you looked at overall survival, there was no difference between the two groups. The last is this retrospective cohort study. And what this tried to address was those lesions, or what optimal lesion, what size optimal lesion is amenable to radiofrequency ablation, and do we get differences in outcomes regarding size? So this was just over 300 patients. 160 of them were less than 2 centimeters, and 130 odd were more than 2 centimeters. And if you look at the survival rates, one can see that the survival rates in both groups are significantly better than if the lesion is left untreated. So the natural history that we referred to in the beginning. And that, yes, there is a difference between lesions that are smaller than 2 centimeters and those larger than 2 centimeters. But even in the lesions larger than 2 centimeters, these numbers, 1, 3, and 5-year overall survival rate is far better than left untreated. So in general, radiofrequency ablation for early HCC, one can expect around a 90% complete response rate. It's best within lesions less than 2 centimeters, and the 5-year survival rate is very good, around 66 to 86%. It comes at the expense of a higher recurrence rate, and I think we just need to appreciate that and maybe tailor our surveillance on patients who we've ablated, rather than to say that ablation is not sort of a good enough treatment. It does have limitations, and the most marked of it is really the heat sink effect. And then just keep in mind that it's a slow heating mechanism, so these procedures do take 30 to 40 minutes in most of the cases. So that's radiofrequency ablation versus resection. So now let's look at microwave ablation versus radiofrequency ablation. And really, when one goes to the literature, one has to be cautious, because microwave, the new generation microwave systems are far superior and far more reliable than the older systems. So really, if one starts looking at data more than 5 years old regarding microwave ablation, one's going to have confounding variables that's not applicable to modern microwave ablation machines. So I'm going to take you through some of the newer data. So this is a randomized control phase 2 trial published earlier this year, and basically looking at microwave ablation versus radiofrequency ablation. They looked at lesions between 1.5 and 4 centimeters. And microwave ablation was superior to radiofrequency ablation regarding ablative zone. So it had a larger ablative zone. But regarding time to progression, overall survival, primary techniques, progression, there was no. So that microwave ablation is at least equal to radiofrequency ablation. This is just a somatic diaphragm looking at local tumor progression on the left and survival on the right, and just showing you that there was no difference between the two. Looking at the complication profile, again, no difference between the two different modalities, which is encouraging. So this is a recent meta-analysis published in 2020. And again, looking at the newer generation microwave ablation units, included 26 studies, of which 5 were randomized controlled trials, but a large sample size of just over 4,000 patients. And what I wanted to put sort of get across here is that the median ablation time for microwave ablation is significantly shorter than that of radiofrequency ablation. So 12 versus 29 minutes. And that's very attractive because that means that we can do these under local anesthesia or conscious sedation. When you start looking at 30 to 40 minutes, it does become tricky to keep your patient comfortable. And again, no significant difference in overall survival or disease-free survival between the two modalities. The last is this meta-analysis of randomized controlled trials published in 2020. This included 7 randomized controlled trials. And again, between the two modalities, there was no difference between response rate, survival rate at 1 and 5 years, local recurrence rate, and adverse events. There was, however, a benefit in microwave ablation regarding 5 years recurrence rate for disease-free survival. And it also favored microwave ablation regarding distant recurrence rate. So those theoretical benefits that we've all been expecting from microwave ablation seems to be shown in this meta-analysis. So the big benefit is the decrease in heat sink effect. It has larger ablative zones, but still the best data is for those lesions less than or equal to 3 centimeters. It's got short procedural times. And really the take-home message for me is that modern microwave ablation systems are equal to radiofrequency ablation, with the potential, hopefully more studies will come out with additional benefits. So this is just a ultrasound that is showing you the lesion in segment in the picture top left here in A. The ultrasound probe within the lesion, this is what we call the popcorn effect. And ideally what you want is this hyperechoic tract with this hypoechoic rim around the lesion afterwards. This is a follow-up CT scan of the patient. And again, here what we look for is this inner, I'm not sure if it's projecting well, this inner hyperdense core with this outer thick hyperdense annulus showing a good ablation. So that's microwave ablation versus RFA. So now we're going to look at RFA versus percutaneous ethanol injection. So this was addressed really in a meta-analysis of randomized controlled trials published in 2015. There were 18 trials included, and the authors found that there was a discrepancy between the Asian studies and European studies. The Asian studies suggest or showed that there was a benefit in radiofrequency over percutaneous ethanol injection regarding overall survival, complete response rate, local recurrence rate at 1 and 3 years. The European studies, however, showed that the overall survival was equal, but RFA did have a low recurrence rate at 3 years. So this is just the trials that were included, and I don't expect you to see that, but what I wanted to put across here really is that if you go back to what untreated HCC is, the 3-year survival rate of 41 and 5%, percutaneous ethanol injection has a fantastic 3-year survival rate in comparison. These are just forest plots showing exactly what I've shown, what I've just mentioned to you regarding the overall survival, with the European studies at the top here and the Asian studies at the bottom. And again, the forest plot regarding 1-year recurrence rate between the two modalities. Ethanol injection is, however, very cheap. It's very well tolerated. You don't need specialized equipment. It's actually favored in certain tumor locations. You can use it in conjunction with, for example, RFA, which is shown to improve overall survival and recurrence rate. And really, it's significantly better than the natural history. So this is something, again, that I really would suggest that HPB surgeons become familiar with doing and performing. So in summary, Liver resection versus RFA. Small lesions less than 2 centimeters, similar overall survival, but possibly poorer local recurrence rate and disease-free survival. But we can probably overcome this by changing our surveillance strategy. Microwave ablation versus RFA. There's a decreased heat sink effect. It can be used for lesions up to 4 centimeters, and more recently this has been challenged by the Legacy trial, which has shown benefits up to 8 centimeters. But that really there's an equal complete response rate, local recurrence rate, the adverse or the adverse effect profiles potentially the same, and there's potentially a better disease-free survival rate for microwave ablation at 5 years. And then regarding ethanol injection, please don't forget about it. It gives very good results, either alone or in combination. It's got numerous benefits, which we've touched on. And really, for me, research needs to carry on focusing on this, because in resource-constrained countries, this is a modality that is really accessible and something that we need to continue improving. And so we should continue looking at it. Thank you. That's all from my side.
Thanks very much, Colin. That was a very comprehensive overview of all the treatment options. I think let's move on to the first case, and then we'll take questions at the end.
Okay, so the first case is going to be presented by Dr. Mazwe Punguchi. He's our senior HPB fellow, and hopefully he's going to take you through another case that we fortunately were able to provide some type of treatment for. All right, your slides are starting to come through. They're just in the sort of presenting view at the moment. All right, Mazwe, I think you're still muted at the moment, but your slides have come through nicely.
Good afternoon, everyone. I'm Mazwe Punguchi. I'm a surgeon here in Bloemfontein, and at University of Free State HPB unit. I'm going to present a case now here. Just a minute.
Mazwe, I think we see it quite well in this mode as well. So you can, okay, there we go.
Okay, all right. I'm going to present the first case of an HCC. It's a 64-year-old male with a good performance status of one with a background history of chronic hepatitis, no use of alcohol, and HIV negative. He presented with left upper quadrant pain and had an incidental finding of a liver mass with features in keeping with HCC on a triple phase CT scan. All right, just gonna move on a bit there. This is in summary the blood results and just a preoperative assessment there. is a 64-year-old child, PUA, and with a MEL score of 7, is a very preserved liver functions, as you can see there, and as we said, background history of chronic hepatitis, and had a normal alpha fetoprotein of 2.4. All right. Now the next slide. I'm sure I was hoping to show this the CT scan itself, but we just had a bit of problems with showing that. But then I just put up this these three scans, but it's a nice I mean features of HCC. So you can see in a triple phase CT scan, but an arterial, portovenous, and the late phase. We have that enhancement in the arterial phase there. It was a heterogeneous mass. And you have there decrease enhancement there. I mean hypoattenuation in the portovenous phase, and then there's a late phase. We have a washout there. And then I just because there's no scan here, when I just say that you can see that it involved actually segment 2 and 3, and the left. I mean, the left hepatic vein was to the left of the, I mean, to the right of that mass, push away a bit to the right of the mass, was not involved, and then the portal vein and the hepatic artery as well, not involved. So that's the CT scan in short. All right.
I wonder if we could maybe stop there and just ask any of those online, maybe from one of our northern sort of neighboring countries, if they wouldn't mind offering their opinion as to what they would do for this patient. I'm not sure if there are any, probably not going to get anyone volunteering.
Colin, the one issue here that I think this case nicely demonstrates is, you know, I think this patient is probably non-cirrhotic. And that's one of the nice things that we see in sub-Saharan Africa. A lot of these patients with hepatitis B are non-cirrhotic. I was just wondering, did you do a laparoscopy to confirm that the patient didn't have cirrhosis, or a biopsy, or did you just proceed to surgery?
So in this specific case, Mark, we actually went to surgery with the idea of resecting, but that if the patient was found to be cirrhotic on the laparoscopy prior to this, or at the same setting, that we would then biopsy and sort of try quantify the severity of it. Yeah, this was one of our this was actually our first laparoscopic case performed. So like I said, we had the sort of the ability to have a look at the liver before deciding to resect.
Okay.
Yeah.
But I think it's notable, Mark, if I may just come in. I mean, if you look at the liver, it looks like quite a well-preserved parenchyma.
Yeah.
If you look at the contour, there's not that much of a big segment 1. And then also the spleen, what I can see of it there is really quite small, so it's probably not. So
you could argue hypertension. Yeah, Ed, you could argue even if there is cirrhosis and there was such good liver function, you would still probably get away with resecting segment 2 and 3. So yeah.
And then ideal case for a laparoscopic resection. So well done.
Yeah, Prof. Maybe I mean. Seeing, I can maybe ask you. I mean, this for us, the big question here was whether or not we should try this laparoscopically. The concern for us is that we don't have laparoscopic ultrasound, so we really are limited by the fact that unless it's an anatomical resection and we've got clearly no vascular involvement, we've got no way of telling that we're not going into the tumor unless intraoperatively we suddenly find ourselves.
So intraoperative ultrasound, sometimes it's helpful in these patients, but as we've learned from cirrhotic livers, if you don't have ultrasound contrast, you sometimes sit sort of in a sea of nodules, of regenerative nodules, and the ultrasound doesn't really tell you which one is which one. So I think it's acceptable to just sort of look at do your pre-operative imaging as well as you can, and then you basically have to rely on that. And I mean, there's a little bit of evidence coming now that your risk for liver failure is actually less with laparoscopic resections, especially in cirrhotic patients, than with open surgery. All right. I think just in the interest of time, Mazwi, did you have anything more to say, or can we go on to the second case?
No, just a few more slides. Yes, as Colin has said now, we did a laparoscopic left lateral sectionectomy. I think Colin has already indicated our limitations in terms of laparoscopic probes. And then other issues, we do not have laparoscopic sets for advanced liver resection as well. That's our problem. But we do have, however, this with for small resections like this, we can go laparoscopically. All right. So this was the histology of this patient. And see there was a 11 millimeter margin, negative margin there. It came out as a well-differentiated hepatocellular carcinoma, and that was the size of it there. All right. Now, I think Professor just spoke a little about laparoscopic versus open resection, and indicated this about I mean, spoke about the liver failure. This was also a meta-analysis comparing laparoscopic versus open liver resection. Here they were looking into the efficacy and the safety of laparoscopic versus open, and the evaluated endpoints were to look into operative outcomes and postoperative outcomes. And as you can see here, the laparoscopic groups actually did very well as compared to open in terms of minimal blood loss, less transfusion requirements, and less length of hospital stay, and then also less postoperative ascites. And as Prof indicated, the liver failure as well, less liver failure. And then there was a trend towards favoring laparoscopic in terms of lung complications. So in those left on the right side, there were no significant difference in terms of those the bilic, the post-op bleeding, and abscesses, intraabdominal abscesses. As you, in terms of mortality, you can see actually here there's not much difference, but however, you can see that it favors more laparoscopic. The trend goes in favor of laparoscopic liver resections. There's less mortality on the laparoscopic group. And then this, in terms of the resection margins, there was less positive resection margin. Little trending towards the laparoscopic group, but there's not much difference between the two. Significant difference between the two. So yeah, that's the case there. Thank you.
Thanks, Mazwi. So I think let's move on to the next case. While we're doing that, there was a question. So we can, Dr. Kurchenikov can start loading it, but there was a question about transplantation. Would you consider liver transplant here? Seems within criteria, potential referral to transplant center. So I think I'll try and answer that quick while we're loading it. My feeling on that is, you know, you've got a patient with very well preserved liver function who's not cirrhotic, and it's an easy laparoscopic liver resection. I think in this case, resection is a way better option in a non-cirrhotic liver, because you're going to avoid the need for immunosuppression down the line, and you're going to not have a delay in trying to wait for the patient to be transplanted. So I think in a non-cirrhotic liver where the lesion is resectable, resection is probably the better option. I don't know if anyone has any comments about that.
No, Mark, I think the only thing to take into account is whether or not there's satellite lesions found on imaging, because then you know that the recurrence rate is going to be high, quite a lot higher.
In this case, they weren't, and I think
no, not in this case, no. So the next case, I'm really looking forward to the input here. So please, everyone, get involved. It was a very challenging case for us, and I'm still not sure we managed to provide the best care for this patient. So we're looking forward to hearing your comments here. Andre, are you able to?
Yeah, just 1 second. Which is just 1 second. Apologies, 1 sec. Here we go. Can you see my slides?
They haven't come through yet.
Not yet.
Yeah. Yeah.
There we go. They're coming through.
All right. Thank you very much for having me today. I'm going to be presenting a case of hepatocellular carcinoma. My name is Andrei Kirpichnikov. I'm working at Universitas Hospital in Bloemfontein. So we will be talking about Mr. J, who is 62 years old, and he was referred to us from GP practice. His main complaint and main presentation was patient had a liver cirrhosis because of iron load, hematochromatosis, and he presented with Child-Pugh class B with a MELD score of 17. He had signs of portal hypertension, ascites. His chief presentation was with grade 3 esophageal varices with rectal bleed. He was a little bit encephalopathic on admission. His mini-mental score was 24. Baseline performance score was 1, diabetes, hypertension, and his AFP was normal. The treatment for him was initial control of variceal bleed, and he was placed on bending protocol. His treatment was optimized for portal hypertension, ascites, for hepatic encephalopathy, and his encephalopathy significantly reversed on medical treatment. It's got much better. It went from 24 mini-mental score to went up to 25. His initial imaging showed that he got solitary lesion in the right lobe, and the size was on the first scan was 56 by 58 millimeters, which increased to 64 to 58 millimeters by 62 millimeters in just 1 month. And it was single right liver lobe lesion on the imaging. This is a screenshot, a spot sign. If you can see the quite large solitary lesion in the right lobe. It was giving also a touch in the right portal vein. This is a famous Barcelona guideline that's of management of hepatocellular carcinoma. And we're not going to go through all of it, but we will just delineate where our patient was. It's basically talking about very early stage, intermediate stage, advanced stage, and terminal stage. Our patient had, in terms of tumor burden, it wasn't that bad. It was tumor burden wasn't that great, but he had problems with decompensation in terms of liver reserve. He got cirrhosis, and he also got portal hypertension, varices, ascites, encephalopathy. So we actually classify him as quite advanced stage. And unfortunately, systemic treatment isn't available in our settings, as just Colin outlined very well in the previous presentation. So his chances were, we were thinking towards giving him, consulting him in our transplantation unit not far from Bloemfontein. And the decision was for him to get TACE, transarterial chemoembolization.
All right, Andre, maybe we can stop there and maybe just get the opinion from Mark and them. So Mark, yeah, long story short, if a lesion just outside transplant criteria.
Yeah. So I think that the difficulty here is the way also that the patient presented with a variceal bleed. You know, and the problem is portal hypertension and his MALT score that's 17. It limits you in your treatment options. Transplant, I mean, I think transplant would potentially be a good option for him. But you know, if you were to stick strictly to the Barcelona criteria, he's actually outside transplant criteria because of its liver function, which is one of, I think, the weaknesses with the Barcelona liver clinic staging system, because you know, transplant works well for patients with poor liver function. The problem here is you're going to have to keep the guy well while he's waiting for a transplant. So the way we would manage it, and I'm not saying we manage these things ideally, would, I think, focus on controlling the bleeding and trying and getting him on appropriate care, medical treatment, and seeing if you can improve his liver function over a month or two. I wasn't quite clear on what the etiology of his liver disease was.
Hemochromatosis.
Oh, sorry, hemochromatosis. So I mean, you know, that you know, it's not alcohol. So if his liver function improved, then I think to proceed to TACE would be a really good option. See if you can get the lesion a bit smaller. And if it looks like he's got good tumor biology down the line, then I think transplant would be a good option. I think resection is definitely off the cards, and it's too big to ablate. So that would be the only way that I could see that he could be managed with curative intent. I don't know, Ed, if you, what do you think about that?
No, I agree, Mark. I just want, there's a whole issue about liver function and liver transplantation. It has been corrected in the latest version of the Barcelona criteria, where they say you don't actually pay attention to the liver function in patients that are on the list for transplant.
In this guy, yeah, in this guy, you'd have to spend a bit of time seeing that you.
Yeah, no, you have to tie, but the decision, liver function is not weighed into the decision whether a patient is eligible anymore, because you know, but obviously you have to keep them alive and alive on the waiting list.
Yeah.
Right.
So just to give you a bit more history, so we actually found that he had imaging done almost 2 years ago, where the lesion was, one could see the lesion almost 2 years ago. So the tumor biology was I think played itself out. It had a good tumor biology. But the questions that we had around TACE was really in the setting of severe, I don't think Andre mentioned it, but it was grade 3 ascites, did respond very well to treatment, but it was grade 3 ascites and the portal hypertension. So TACE in that setting.
I think, you know, I wouldn't rush to TACE in him. I would, you know, he's just had a bleed. I would wait a month or two at least and see that his liver function improves, because although TACE is well tolerated, it can be the thing that, you know, is really decompensated that just pushes you over the edge. So I think you would probably want to wait a little bit with TACE. So I mean, obviously hemochromatosis is a very high risk for developing HCC, and we've also had the same thing where patients have been missed. And I always find, you know, like there's so few of these patients that we get when they're actually treatable. It's such a tragedy if someone misses it like that, like happened in this situation. Yeah. What actually happened in the end? Are you still managing him?
Yeah, I'm not sure if Andre wants to, but essentially, so he's been referred through, and again, it's a limitation that we have. He's been referred through to our colleagues about 500 k's away, for those who are on here, and each time he seems to complicate. It was first with COVID, and then a month later he had another variceal bleed. So he's still on the waiting list. He's outside the normal criteria, so he's being worked up for a living-related transplant.
I think he'll have quite a good prognosis if he's fit. You know, he should have a good prognosis. like you say, he's got good tumor biology.
So I think that's it from us in the Free State. Thank you very much for having us. Really appreciate it.
Yeah, no, thank you very much, Colin and Mazwi and Andre as well for really fantastic presentations. You know, I think we are outside of the big centers where many of us work, we forget how challenging it can be outside of the hospitals where we have all the options, and especially when you sort of start building up a center. And I must say, I really like the almost holistic way in which the problem has been approached in the Free State. And it's really very similar to other presentations we had from countries in sub-Saharan Africa about the real challenges that we face. And what struck me from the beginning is probably the incredible underestimation of the disease in the Free State, as everywhere in South Africa, where the estimations in terms of the incidence of HCC is done, it's actually done on biopsies, either from a biopsy or a explant or a liver resection. And we know that, as you've shown, very, very, very few patients are actually do have histology to confirm it. But really well done, and I think it's a very nice example of how to approach the problem when you attack this magnificent problem that we face in sub-Saharan Africa. So I don't see any other questions. We're a little bit over time, but just remains to thank everybody, Colin and colleagues, for very, very nice presentations. We'd also like to thank the ECHO team in New Mexico, the ECHO team in India that's always very supportive. There is feedback forms available in the chat. We really appreciate any feedback to make the sessions more interesting. And if any of the colleagues have got patients that they would like to discuss that we can all learn from, please feel free to just notify us. And this recording will, as all the others, be available on the Gastro Foundation website. And then again, thanks to the Gastro Foundation, to the presenters, to the sponsors. And I think the next meeting, next Wednesday, is a public holiday. So the next meeting is going to be on the 4th of May, and that will be endoscopy. Thanks, everybody.
Thank you.